heard us. My name is Beatrice Carlini. I wear a couple of hats here at ATTC Northwest. One of them is to organize the webinars. Our webinar series run every last Wednesday, fourth Wednesday of the month. And today we are going to be talking about PrEP, pre-exposure prophylaxis for HIV prevention among people who use substances. We are going to be waiting for 1 more minute. More people are joining us as we speak, and we'll start very soon. We always have a question, which I will already answer in the start, but probably going to have to answer later. The slides and the webinar itself are both going to be available right as we finished in our website, and you can see the link in this slide. Is the same that you have been to also register for this event. I will reiterate this afterwards as well. Everybody's automatically mute, and I think to 12:02, I'm going to start introducing our speakers then. Okay, so we are very lucky to have two extremely knowledgeable speakers today. They are both from University of Washington School of Medicine. So Dr. Stekler is an associate professor here at School of Medicine, and her research centers on HIV testing and HIV prevention. Dr. Stekler is a national expert on HIV tests, particularly focused on acute HIV infection in point-of-care testing. She started the first community-based clinic for HIV pre-exposure prophylaxis. We're going to go for PrEP now in Seattle, and is currently working to increase access to PrEP and PrEP adherence across Washington State. We are also lucky to have Vanessa McMahan. She works with Dr. Stekler, and she's a PhD candidate that comes with a lot of experience prior to joining UW. Her research focuses on PrEP among individuals who use methamphetamine. Prior to her work at UW, she coordinated the study that was the basis for FDA to approve the indication of PrEP for HIV prevention. She's also a hepatitis C care advocate and volunteer in a harm reduction organization here in Seattle. So without further ado, now we go to the transition to the slides here, to the slides with our speakers. I want to welcome you both, and let's get started. So you have to click in the slide now to be able to move them. Thank you.
Great. Thank you, Bia. Thank you, everyone, for joining. My name is Vanessa. I'm going to start off sharing some background, and then Joanne will speak, and we'll loop back to talking about some of our current projects. So our agenda today, briefly, is to talk about HIV epidemiology in the United States. We're going to focus both in the background and later on, mostly on cisgender men who have sex with men and transgender persons who are using methamphetamine. That's the bulk of Joanne and my work. We're also going to talk about people who inject drugs, discuss PrEP, the evidence that's out there, and kind of the current situation with PrEP and substance users, and then our work in Seattle with cisgendered MSM and transgendered individuals who use methamphetamine, and then close with some time for questions. So just very briefly, HIV in the United States, this map is showing the geographic disparity of rates of new diagnoses in the US, and you'll see that the South accounts for more than half of the cases, and the darker purple indicates the increased rates, and so there's really concentration in the Southeast. In addition, there's disparity by route of transmission. So about 2/3 or 67% of new infections are in cisgender men who have sex with men, and 9% are in people who inject drugs. There's really no reliable nationwide data on rates in transgender persons. However, studies show very high rates, especially among trans women, higher in many instances than among cisgendered men who have sex with men. So in all of these cases, these percentages are very disproportionate considering the percent of the population these subgroups are. And estimates vary, but LGBTQ estimates are usually about 4% of the population. Current injection drug users are usually less than 1%, and transgendered individuals also less than 1%. So really a disproportionate burden of new HIV cases in these groups. In addition, 1 in 7 people with HIV do not know that they have HIV, so there's a lot of concern for ongoing transmission and a real need for testing and screening. So this is just kind of a historical perspective on where we've been and where we are with HIV and AIDS diagnosis in the US. This is showing 1981 to 2003. And as you can see, in mid-90s, we really curbed the epidemic in many regards, and transmission and AIDS cases dropped amidst all risk groups, mostly due to increased prevention activities and the onset of HAART, or medication to treat HIV. But you will see that we still have the highest number among men who have sex with men, and injection drug users are still high number of cases. So the dotted line, or the dashed line there, so while decreasing, still remain very prevalent. So just to think of kind of the transmission groups again and disparities, lifetime risk of HIV in the US, this bar chart shows by transmission group. You'll see that men who have sex with men have the highest lifetime risk of an HIV diagnosis, with 1 in 6, followed by folks who inject drugs, and then heterosexual individuals. When you look at it by racial groups, African-American men have the highest lifetime risk of HIV, with 1 in 20, followed by African-American women, then Hispanic men and women, and white men and women. So disparities both racially and by transmission group. When you combine these and you look at race and transmission category, you see really big disparities between African-American men who have sex with men who have a lifetime risk of HIV diagnosis of 1 in 2, compared to Hispanic MSM of 1 in 4 and white MSM of 1 in 11. So really showing that disparities exist both racially and through transmission group or through behaviors. And when you intersect them, we have really staggering disparities. So drug use among drug use and HIV among cisgender men who have sex with men and transgender persons. So kind of taking this transmission group and looking at drug use in this group and this intersection of behaviors. Substance use is very prevalent among the LGBTQ community. Across 20 cities in the National HIV Behavioral Surveillance, they saw that 8% of cis men who have sex with men used substances, and this varies greatly from city to city. And again, there's really no good nationwide data looking at trans populations, but multiple studies in the Los Angeles County have shown that drug use among trans women is as high as 20% in different samples. Meth is associated with HIV risk. Meth has been seen to be associated with 50% increases in risks among men who have sex with men, and even higher increases in risk among trans women. So we know that methamphetamine use is a risk factor for HIV acquisition. And in addition, meth use is increasing in the United States. So kind of taking that and looking at Seattle and our local context, among men who have sex with men in Seattle, meth use is a significant risk factor. Incidence among this group is about 2.3 per 100 person years, compared to non-meth using MSM. It's over a 5-fold increase. It's estimated that meth use may contribute to about 20% of HIV transmission among men who have sex with men. And because they're the bulk of the transmission in Seattle and King County, that's 16% of all new HIV infections in the county. So switching gears a little and talking about HIV among people who inject drugs. Overall, HIV is decreasing among people who inject drugs across the country. However, there's concern for possible slowing or reversing of this trend. I think it's well known that we're having increases in heroin and meth use everywhere in the US, and in certain places in particular. Demographics are shifting when it comes to injection drug use, with more rural drug use occurring. So folks that are traditionally outside of places where testing is offered or harm reduction services are available. And these are some of the factors that contributed to the outbreak in 2015 in Scott County, Indiana, where we saw 181 cases of HIV in a location that in the decade prior had only had 5. So again, increasing injection drug use activities and really lack of services in that community. So we are concerned that those trends, increasing in drug use and lack of services, could spark outbreaks in other locations. So then again, back to kind of the Seattle lens for HIV among people who inject drugs. So historically, HIV has been more prevalent in injection drug users on the East Coast compared to the West Coast for a variety of reasons. One main reason is that heroin is one of the most injected substances, and there's a difference in heroin between the East Coast and West Coast with West Coast heroin being more viscous, more impure, and usually needles last shorter when using what we call black tar heroin on the West Coast. So there's less chance of sharing needles because the needles, the lifetime of the needle is shorter. There's also cooking procedures and rinsing procedures that occur with injection of heroin on the West Coast that may be protective against HIV. In addition, we have generally more permissive syringe access policies and over-the-counter sales policies on the West Coast, and increased needle exchange programs and harm reduction services. So some of the reasons that we've seen more HIV among injection drug users on the East Coast. However, there's concern also for that to be shifting. When we look at the decreases in HIV by coast, HIV is decreasing more among injectors on the East Coast than it is on the West Coast. We also see high rates of increases in methamphetamine injections. So if there were characteristics or are characteristics of heroin that might be protective to less needle sharing and less risk for HIV, methamphetamine does not share those characteristics, and could be, we could see increases in HIV transmission among methamphetamine users. Again, in the intersection of men who have sex with men and injection drug use, men who have sex with men who inject methamphetamine in King County have a high prevalence of 45% of HIV. And importantly, we've been seeing recently that there's been higher rates of sharing between men who have sex with men and non-men who have sex with men. So a recent NHBS study looked at folks that use methamphetamine and shared needles, and about 43% of the MSM were sharing with non-MSM. So there's concern there for emerging populations at risk. And finally, to kind of exemplify some of these concerns, recently there's been a cluster of new HIV cases. It's 10 and potentially growing in Seattle in people who inject drugs in the northern area of Aurora. And so this is a population that we, in the past couple decades, we really haven't seen at risk for HIV, and there are some new cases that are of concern. So I'm going to turn it over to Joanne to talk about PrEP and how it can work to prevent HIV.
Great. Thanks, Vanessa. So this is Joanne Stekler, and I'm going to give you a brief overview on HIV pre-exposure prophylaxis, talk a little bit about the details of what PrEP is and disparities, and then I'm going to pass it back to Vanessa to talk about our work. So what is PrEP? PrEP, pre-exposure prophylaxis, is HIV negative people taking HIV medicines before they get exposed in order to prevent them from getting HIV. And currently, as of September, whatever day today is, that only M-tricytidine and tenofovir disoproxil fumarate, also known as Truvada, as a single pill, it is the only medication that is currently FDA approved for PrEP and only FDA approved for daily use. This slide shows all of the randomized studies that were done in the early 2000s to starting to show results first in 2010. All of those randomized trials that enrolled different populations, heterosexual men and women, discordant couples. The IPREC study, which Vanessa was involved with, enrolled almost 2,500 men and transgender women who have sex with men. And then there's one study that I'll highlight in just a second that was a study of injection drug users in Thailand. But what you can see on the right is there was a range of efficacy shown, from no effect of Truvada to a protection, a decreased risk of transmission, of acquisition, of almost 90%. And we'll talk about the reason for that in a second. Again, here is the Bangkok TDF. It stands for the tenofovir disoproxil fumarate, TDF study. And this study enrolled just over 2,400 people who inject drugs and randomized them to daily intakes of either oral tenofovir alone or to placebo. 4 years, and this study showed a reduction of HIV infection in the modified intent to treat analysis of 49%. And it was 77% protection in the group who had any drug levels detected. This is the one study that supported the FDA approval and the CDC guidance for use of PrEP in people who inject drugs. But what I've been hinting at in talking about this range of efficacy among these trials is the importance of adherence. And what you can see on the slide is a few of those randomized trials ordered on the top of this list, the study, the Partners PrEP study, that was a study of discordant couples, and at the bottom, FemPrep and Voice, which were studies of heterosexual women in sub-Saharan Africa. These studies are ordered from top to bottom based on the estimate of efficacy and the modified intent and treat analysis. What you can see in the right column is when each of these studies took their individuals who were supposed to be on drug and tested them for any detectable levels of tenofovir, that it patterns very nicely with the efficacy data. So the study that had the highest efficacy, the Partners PrEP, had the highest proportion of blood samples in which the PrEP medicine was detected. And in the studies at the bottom that showed very little or no efficacy at all, very few of the specimens from individuals who were supposed to be on active medicine actually had tenofovir detected. Now, if you are someone who likes figures instead of tables, this figure shows efficacy on the y-axis and that proportion of blood specimens on the x-axis, and there's a very nice linear association between adherence, or having the blood levels detected, and how well the study works. So in summary, what I like to say this as is PrEP works if you take it, and PrEP does not work if you don't take it. I just want to move a little bit into sort of where we are since 2012, since PrEP was FDA approved in the United States. Vanessa showed you a map earlier in this presentation where the new cases of HIV are centered in the South. And what you can see from the slide is that the rates of PrEP utilization, at least a couple of years ago, were not in the South. They were, although in Florida and New York and Chicago and California and in Washington State. So we really need to do a better job across the United States of getting PrEP into the hands of people who are at most risk for HIV infection. So that's the geographic distribution. What I'm going to show you on this slide is the uptake by race ethnicity. And in the pie chart on the left, you can see the estimated population distribution by race ethnicity in the United States as of 2014. I'm going to ask you to focus on the blue, black, and red slices. So the blue slices represent whites or Caucasians, who represent 62% of the United States population. Folks who are Black or African American represent 12%, and folks who are Hispanic or Latinx are 18%. If you pop over to the right pie chart on the very right, what you can see is that 27% of the new HIV infections in the United States as of 2014 were among individuals who are white Caucasian, but 44% are Black African American and 23% Latino. Again, speaking to the disparities in HIV infection that Vanessa mentioned earlier. And similar to the geographic distribution and us not getting PrEP into the hands of the people who are most at risk, what you see in the middle pie is the estimated uptake of PrEP by race ethnicity in the United States. And although white Caucasians only represent 27% of new infections and 62% of the population, they represent 74% of the PrEP prescriptions. And we are not doing as well in getting PrEP into the hands of African Americans and Latinx persons, who represent only 10 and 12% of the estimated PrEP prescriptions in the United States. Also thinking about people who use substances and focusing on them for the next two slides in terms of what we know about PrEP knowledge and uptake. There are, as I mentioned earlier, only the Bangkok study that showed PrEP efficacy among people who inject drug. And even that study had a cohort that was relatively low risk for HIV acquisition. Among their people who inject drug, only 45% of them actually injected during the study period, and only 2% of them reported sharing needles and works during the study. I think sort of as we think about expanding PrEP services, similar to sort of how we thought about expanding antiretroviral services in Africa sort of in the early 2000s, there's some controversy about whether we should be offering PrEP in a variety of settings who don't yet have access to syringe exchange programs and opioid substitution therapy. So just something to think about and contemplate as we think about expanding these programs. And there are modeling studies, because sometimes we use modeling when we don't have the efficacy data, that modeling studies show that while PrEP is effective at preventing HIV among people who inject drugs, PrEP may not be as cost effective as syringe exchange programs and opioid substitution therapy programs. Now, I say this with the caveat that the modeling studies use as their inputs estimates from the Bangkok-Tenofovir study, which may have lower estimates of efficacy and adherence that we see in the real world. One of the things that we saw as PrEP has moved into the open label extension and the demonstration projects is that adherence has generally been better in people who knew they were getting an active medication and they knew that that medication worked if they took it. So the challenges that we've had in adherence in the randomized clinical studies, although they continue, we actually see higher adherence in the real world than we did in randomized studies, which is really a surprise for research. What we know about uptake among cis heterosexual men who use stimulants, and we're focusing on stimulants and particularly on methamphetamines because that's where the risk is here in Seattle, that there have only been a limited number of studies that have looked at this. And although both of these studies have shown high rates of familiarity, they knew what PrEP was, or at least that PrEP existed, and there's high rates of interest in taking PrEP among these populations, there has been low rates of PrEP uptake, down to the 3 to 5%. And many of these folks report that cost is a common barrier to or perceived cost is a common barrier to their going on PrEP. And we can talk about cost if people have questions about that. When we started doing this work a few years ago, there was pretty clear data that methamphetamine users were underrepresented in our local clinics, including in the pilot project that I started in 2013, and then our continued safety net clinic at Gay City. And then we have a pharmacy-based program that was started at Kelly Ross by Elise Tung a few years ago, and they also see few methamphetamine users. And then our state drug assistance program in its early years had few individuals who were methamphetamine users on their rolls at that time. So we felt pretty strongly, given that methamphetamine users were at high risk of HIV and appeared to be underrepresented, that we should embark on this work. The other thing before Vanessa tells you about our work is sort of understanding what additional work needed to be done, not only to increase knowledge and uptake among stimulant users, but also what barriers there would be around adherence, again, because PrEP only works if people take it. And there's been mixed results from the studies to date. In some demonstration projects, there's one demonstration project, it's actually been a couple of demonstration projects, one that occurred in San Francisco, Miami, and DC, and another in San Diego. There was no difference in adherence among individuals who did or did not use any stimulants. And in the analysis of the IPREX randomized control trial and a large cohort at Kaiser Permanente, that methamphetamine use is associated with suboptimal adherence. So some mixed results as we moved forward in this work. And so just to summarize the background that Vanessa and I both presented, again, cisgender men, heterosexual men, and transgender folks and people who inject drugs are disproportionately impacted by HIV, and cis men of sex with men represent the majority of United States cases. Folks who use methamphetamine are at elevated risk. And interesting and concerning, meth use is increasing, and there is concern for emerging risks among the people who inject drugs who are not men of sex with men, as we're seeing in this small cluster here and we have seen across the United States. I hope I've given you a brief overview and shown to you that PrEP is safe and effective with limited data among drug users, and we can talk about this more if there are questions at the end. And PrEP uptake to date has been slow among cisgender men who have sex with men and transgender folks who use methamphetamine, and this is what Vanessa is going to share some information with you in the next few minutes.
Great, thank you, Joanne. So we're going to talk about kind of two big projects we've been working on the past couple years. The first was a lot of formative work that helped develop the second, and the second is the current pilot study we're doing right now. So I'll start with a small grant that we got from the UW Alcohol and Drug Abuse Institute, looking at the same population that we've been describing, so cisgender men who have sex with men and trans individuals who use methamphetamine in Seattle. The main aims were to assess the knowledge and perspectives of the NEON peer educators, and I'll describe who they are in the next slide, regarding PrEP use among this population, and then to develop and pilot educational materials regarding PrEP that are targeted to meth-using men who have sex with men and trans folks in Seattle, and then to increase the knowledge and uptake of PrEP among this group. So for this project, we decided to partner with some collaborators we've worked with prior as well. Project NEON, which is a harm reduction program for methamphetamine users. It's part of the Seattle Counseling Service, and they promote wellness in the LGBTQ population. Their mission is to raise awareness about the links between meth and HIV, STIs, or sexually transmitted infections, to increase the use of sterile injection equipment, promote safer sex practices, and support clients to decrease or discontinue their meth use. So about 10 peer educators, and they helped us recruit for the surveys we'll describe, and they participated in our focus groups. So this is a schematic of that study. You'll see that there's kind of two levels. The top level is the peer educators, and the circles indicate the focus groups we did with them. We did 3 over time. And then in the interim, we did educational material development. And in the bottom are their contacts that they helped us recruit with, and we did 2 surveys. So first, we'll describe briefly the survey results that describe the contacts that peers work with. And the peers were great stakeholders for this population, especially because in other ways they've been somewhat hard to reach. And so they were really great collaborators and have worked with this group for a long time. So first, the baseline survey we did in August 2016. The vast majority of folks had heard of PrEP, or 97%. However, as Joanne mentioned earlier, very few had taken it. So it was 3% had taken it, and of those 3%, the majority were currently using it. We asked all folks if they knew where to get it, and the majority said yes. And one thing not on the slide is that all of the majority were also insured. And so we kind of left this survey a little perplexed with seeing such high rates of insurance, familiarity with PrEP, knowing where to get it, but very low utilization. We also asked folks in the baseline survey about their concerns about PrEP, and you'll see in the red box kind of the most endorsed concerns. By far, the thing people said most that they had no concerns, followed by that it wouldn't work to prevent HIV, and then the next 2 were really around meth-specific concerns, one being that it wouldn't be safe to use while using methamphetamine, or that it might not work as well. So we kind of used this and worked with the peers to try to figure out the best educational intervention for this group, to try to increase utilization, and to also try to address concerns that might be around meth specifically. So our kind of main focus group findings, summarizing our experience over the year with them, was there's really a need for accurate information. Both the peers had needs for information as well as the community that they engage with. They really identified a lot of methamphetamine-specific barriers to both uptake and adherence, things like competing priorities to make appointments, and with adherence, things like losing days. So using methamphetamine on a Monday, and the next time you realize what day it is, it's Thursday, and you've missed 2 days of pills. And so really trying to figure out ways to support PrEP adherence among folks that might have a hard time planning or kind of knowing when a new day has come. Stigma was a barrier to PrEP engagement across the continuum. This image at the bottom of the slide shows a continuum of care that's been very frequently used in HIV treatment and prevention. If you look at the 5 white bars or unfilled bars, the steps are to identify people at risk for HIV, in this case sexually active men who have sex with men, and transgender folks, that they're aware and willing to take PrEP, that they have access to healthcare, that they're likely to get a prescription, and that they'll be adherent. And so kind of showing that each step is necessary to have effective PrEP use, and at every step you might be losing people that are good candidates for PrEP. The peers really brought to light how much stigma impacts engagement initially and increased risk in this group, and engagement across the whole entire continuum. And stigma was not just related to one identity, but multiple marginalized identities, including being methamphetamine users, the stigma of potentially going on PrEP and judgment around that, being LGBTQ, stigma against HIV positive people, as well as stigma against HIV negative people, really stemming from a lot of HIV prevalence in this community, healthcare worker assumptions, and concern of risk disinhibition, which is the idea that people's risk behavior will increase by taking PrEP. So we saw a lot of stigma and really thought that we should incorporate that in our work moving forward. So just 2 quotes to kind of highlight these findings. The first says, "I make sure my doctor doesn't know that I use meth. I mean that is just an outright, they don't need to know that. I would never admit to it, because if you do, I mean there's all sorts of consequences." So again, somebody that is showing that they're not telling their doctor they're a methamphetamine user, which might diminish their candidacy for PrEP if their doctor doesn't know it's something they should be talking about with them. And the second quote, "Most people I talk to about PrEP, they're afraid that they're not going to be able to keep up the consistent use of it while they're doing drugs, because when you do drugs, particularly if you're injecting, you know it, you lose focus on anything except for whatever you're going to do, like the sex or whatever." So showing kind of a myopia around drug use that can conflict with pursuing PrEP. So we made educational materials in collaboration with the peers. This is an image of one of the cards we made with some non-judgmental wording on the front, a statement around it being okay to use crystal methamphetamine while you take PrEP. PMP and PrEP is meant to kind of call attention to folks that are in the party and play scene or using methamphetamine and having sex at the same time. And then some tips for taking on the back with a phone number for the clinic. Joanne is a director of Ethnicity. So we did a follow-up survey after we disseminated cards and had these focus groups. Again, the vast majority had heard of PrEP. At this point, many more from our sample, which was smaller, had taken PrEP. The majority were still using it now. The 2 most frequently reported concerns at Followup were, "I don't think I can afford it," with about 44% saying that, and "I don't know enough about it," with about a third. We did not ask either of these questions at baseline, but they really came out of our conversations with the peers in the interval because we heard that there were concerns around costs, and we noticed a clear need for information and education around PrEP. So based on our findings from the baseline survey, where most people had known about PrEP, but very few were taking it, we wanted to drill down and really understand what this knowledge of PrEP was, and if it was just a familiarity with the term, maybe overheard by a partner or a social group, or if people actually knew the facts about PrEP. So in the final survey, we asked folks about 5 facts about PrEP and asked them to indicate if they thought they were true or false. As you'll see here, the top bar, only 11% of respondents said that they thought health insurance covers the cost of PrEP. So consistent with our findings and other places that information about cost and getting education out there around coverage is important. About a third thought it was safe to use. A little less than half thought you should take it every day. Joanne clearly went over the data around it, the need for adherence and near daily adherence. A little over a half said you need to see a doctor while you were taking it, and the majority thought it was a way to prevent HIV. But here you can see there's still a lot of needs around getting education about some basic components around PrEP to this community. We did also assess the exposure and impact of our educational cards. A little over half, or 53 out of 100 participants in the final survey had seen the cards. 21 of them had called the clinic number. We did see a trend between seeing these cards and PrEP use in the final survey. And then we asked folks if they believed the statements on the cards, which were also PrEP facts, and they were more likely to be believed, or people were indicated they somewhat or strongly believed them if they had seen the cards. So kind of just letting us see that the educational cards might be increasing education, exposure to education, and endorsement of PrEP facts in this population. So this work was preliminary and formative work to the current study that Joanne is the PI on and I'm helping coordinate, which is an R34 pilot intervention to improve the HIV PrEP cascade that we talked about before, the continuum of care among methamphetamine users. And one is to conduct a pilot randomized controlled trial to evaluate the acceptability and feasibility of a peer navigation intervention for meth using cis men who have sex with men and transgender individuals. And aim 2 is to evaluate acceptability and impact of two-way text messaging on meth use and PrEP adherence. And so this work really came out of our formative work pointing in the direction of support from peer navigators and reminders of text messaging potentially being 2 interventions that could help support PrEP adherence in this group. So we did additional formative work once we started this project with focus groups and interviews with the target community to discuss the specific study aims of this project and our approach, to review the text messages that we were proposing to use as reminders, and to brainstorm educational messages, recruitment materials. So you'll just see a car with similar ideas, but modified a little bit. We broadened our input in this formative work to different interviews and different focus groups, and so our materials were modified a little bit, and our text messages were refined. So eligibility for this study is that the participants need to meet the clinic's PrEP criteria. This study is being done at Gay City and at Kelly Ross Pharmacy, both of which Joanne talked about earlier. And so first, someone needs to meet the clinic's particular PrEP criteria. If they meet that PrEP criteria, they can then be assessed for eligibility for the study, which is being 18 years or older, being a cisgender man or on the transgender variant spectrum who has sex with cisgender men, trans women, or trans men, reporting really current meth use or meth use in the past 3 months, having a cell phone that can send and receive texts, and intending to remain in the area for at least 6 months. So folks that are eligible and consent will be randomized to one of 4 arms. Clinical standard of care, so we're aiming for 40 participants. So 10 will be enrolled to clinical, or will be randomized to clinical standard of care, which is getting PrEP at the clinic according to their procedures. 10 to that plus text messaging, 10 to that plus peer navigation, and 10 to standard of care plus both the combined intervention of text messaging and peer navigation. And again, these arms were developed really based off our formative findings, the importance of reminders, especially when folks might be losing days from methamphetamine use, and the potential benefits of a peer to kind of help with competing priorities and with folks' other needs. So our text messaging intervention, and this is an image here of 3 of our texts, is 3 a day. We also kind of came to that conclusion with our formative work, looking at how many texts would be too many, too few. 3 a day seemed to be reasonable to our participants. 1 will be a PrEP reminder. 1 will be a general PrEP message to try to continue increasing education and information about PrEP in this group. And then 1 will be from chosen categories. So we ask all participants in the baseline survey what else they want to learn about, anything from, meth-related, health tips, general health, sexually transmitted infection prevention, injection-related harm reduction, and they can select as many categories if they like, and they'll get a text every day if they're in that group with information from those categories. And then one thing we heard across all of our formative work is that using emojis was critical, and so our texts all have emojis. The peer navigation intervention is really an individualized intervention that is going to respond to the needs of the participant. So the peer navigator will schedule an in-person meeting within the first week of participation and will provide assistance, including with insurance or other paperwork, assistance with refills. They can send appointment reminders and assistance scheduling appointments. They can offer to attend appointments and facilitate transportation. They should be checking in about adherence in an ongoing way, since it's such a critical component of PrEP use. And they can also provide referrals as appropriate for housing or mental health support or any other needs that a person has. The peer navigator will meet with the participants in that group at the beginning of the study and really do a needs assessment and find out what needs that participant has and individualize their peer navigation efforts to be consistent and responsive to those needs. This study has follow-up for 6 months. Folks in the study, participants, will get regular PrEP clinic procedures at months 1, 3, and 6. They'll also get additional research procedures at their follow-up visits. We will collect dry blood spots for PrEP adherence so we can see if folks are taking their Truvada. And we'll also ask folks to complete online surveys at months 3 and 6. For completed surveys, everyone gets a $20 Amazon gift card, so there is an incentive for participation. And we will do qualitative interviews with participants in the study. So conclusions kind of our work over the past couple years and inclusion of some stuff in the background is that PrEP is safe, effective, easy to prescribe, and covered by insurance, and its use is increasing in both Washington and the United States. Education about PrEP and covering the cost of it remain a priority. Cisgender men who have sex with men and transgender individuals who use methamphetamine experience stigma as a barrier to PrEP uptake and engagement across the continuum. So it's important that our interventions really try to address the stigma and lower it. There are meth-specific barriers to PrEP use, and we think that sending reminders and peer support may help with PrEP adherence among folks that are using methamphetamine. So as we talk about PrEP today, we just want to highlight this. This is just one piece of the HIV prevention puzzle, and there's a lot of different methods and strategies that work for folks that we need to work together and use all of these methods to try to curb the epidemic more. So HIV testing and serosorting, condoms, specifically with injection drug users, needle exchange is a critical component of prevention methods, vaccines, and HIV and STI treatment. We also, as we talked about before, there seems to be a lack of testing, and so really getting testing out there and screening folks so folks know they're positive is an important piece, and a way to access PrEP as well. And then on an individual level, PrEP is also just part of the larger puzzle. And so while folks are using PrEP, they might have other concerns around mental health, or might be trying to engage in drug treatment, or have relationship needs. For folks that can get pregnant, they might be wanting to conceive. Also, housing and homelessness might be an issue. So really need to think about ways that our interventions can help people in other areas of their life so it can support their PrEP use and keep them engaged. And we can also make sure that they have a holistic experience. So to end, we would like to acknowledge at the University of Washington, Michelle Andrasik and Kayla Banta-Green, Smitty Buckler, the peer of our pilot project we just discussed, Lisa Neiman and Lauren Violet, Gay City and Kelly Ross, our study participants across all these activities, Project Neon, our peer counselors, Lindsay Garsky, Alex Martin, and Ann McGettigan, and of course our research support, which comes from the Alcohol and Drug Abuse Institute, the Washington Department of Health, and the National Institute on Drug Abuse. So, yeah, I think that's it. Okay.
Okay, well, thank you very much. So before we hook on, we are transitioning here. Okay, so before I start questions, thank you so very much for your excellent presentation. That is very helpful to hear. So first of all, please, for you guys, participants, consider answering our surveys. It's very important for us to keep doing the work we are doing, that we have your evaluation and feedback, how we are doing, both for reporting purposes from our sponsor, but also so we can do a better job. So you're gonna receive one now, is like as you probably already have your inbox, or right after we finish this, and then once in a month you're gonna get a second one. Please consider answering this. So participants have the chance to type the questions in the chat box. We don't have many of them right now, so we are going to do two things. First, I have some questions, and then second, if time allows and we don't have questions for the audience, Dr. Stekler and Vanessa have some other slides, 3 or 4 other slides that will give you more resources on this topic, and we will transition to them if time allows. So my first questions are related to the risks of taking PrEP. What are the risks and side effects that people experience? And then the other one will be about cost and insurance.
Okay. Bia, do you want to share the extra slides that we had?
Yes.
Are you going to give me control again?
Yes, we can do that. Hold on just a second.
Okay.
And then you're going to have to also click on it. Okay?
Yes, thank you.
Okay.
So this slide that's on your screen right now is actually just about additional resources that you can use for PrEP prescribing, including the UCSF, the University of California, San Francisco Warm Line for PrEP, and then medication assistance programs, which I'll tell you about in a second. I need to do that to make it move. So let's talk about your first question, which is about the risks. And we sort of think about them in a couple ways. The first is side effects, short-term and long-term side effects. So what I tell people that most people have no side effects or any consequences of PrEP at all. But a small proportion, less than half of people, will have a startup syndrome that occurs in the first few weeks after people start taking PrEP, just as often they do with any medicine. And those typically include headache, stomach-related stuff like nausea and bloating, maybe some diarrhea, and then fatigue and weight loss was also reported in some of the randomized clinical trials. In almost everyone, these symptoms go away by the first month, and very few people have to stop PrEP because of that. So we just try to support people through these symptoms. And sometimes if they're having stomach-related side effects, sometimes taking pills with food may help. Sometimes people also find that taking their pills with food makes it worse, but it's just something to play around with. The two longer-term side effects we worry about are kidney and bone. Having a normal kidney function, which is, according to the FDA, a creatinine clearance that is estimated by the Cockcroft-Gault formula of greater than 60 milliliters per minute, is required in order to start and to continue PrEP. And so that requires a blood draw for creatinine and check a weight and get their age, and you have to correct for those in order to estimate the creatinine clearance. They also recommend doing this for ideal body weight for individuals who are overweight, obese. And monitoring is currently recommended at least every 6 months. Both the kidney and the bone side effects were seen in less than 1% of individuals who had been on PrEP for over a year. And in almost all individuals, the abnormalities revert when people discontinue PrEP. The other one that we worry about are bone effects. So, when people lose bone density over time, that's osteoporosis. That is not what we're talking about related to PrEP. There's just a small but statistically significant loss of bone density in individuals who are on PrEP for long term. Again, no one is going to fall down on a dance floor and break a hip, but it's something that we want to be aware of, particularly in individuals who are young and maybe still forming bone. Because we're up here in Seattle, I generally recommend that everybody here in Seattle take vitamin D during the wintertime, but there's no formal recommendations for either vitamin D supplementation or for DEXA scans to monitor, although this might change as recommendations change. I think we have two other concerns that this slide just shows that there are other possible products, again, not currently FDA approved, that may not have those kidney and bone side effects that are currently being studied. But the only thing currently available is the combination pill of tenofovir disoproxil fumarate plus emtricitabine. The other concerns that people have, and I don't have slides for, one is the concern about drug resistance, and the other, as Vanessa mentioned, is about behavioral disinhibition, or people having more sex or using condoms less. And the concern about drug resistance is primarily one in which people start HIV medicines when they're truly HIV infected. So in those randomized clinical trials, many of those trials were using oral fluid HIV antibody tests only in order to indicate that someone is HIV negative. And a small number, and I don't remember that off the top of my head, in all the studies started PrEP when they were antibody negative but RNA positive. What we call acute HIV infection with the viral load is very high. And PrEP being 2 HIV medicines is not enough to reduce the viral load down to undetectable level. And therefore, there was a very high risk. About 1 in 3 of those individuals developed drug resistance. In the individuals who started PrEP who were not HIV when they started, there was a small number, I think, and it was sort of in the couple percent, who developed drug resistance above the baseline level of drug resistance in the community. And although it's a concern, particularly because the medicines that we're using for PrEP right now are also the first-line medicines for treatment, that the prevention benefit of PrEP far outweighs that risk for drug resistance. And it's sort of an estimate of at least 20 infections prevented for every case of HIV that acquires drug resistance. So although drug resistance is a theoretical concern, and maybe for an individual, it is not a reason to not use PrEP. And similarly, we haven't seen very clear reasons not to prescribe PrEP because of behavioral disinhibition. The concern would be that people go on PrEP and then all of a sudden what they're doing overwhelms the protection benefit. And although people do different things when they start PrEP, some number of people do use condoms less frequently or have more partners. There's also a sizable number who continue to do the same and just use PrEP as an added layer of protection. And then finally, there's a small number of people who go on PrEP who actually use condoms more or have fewer partners because they are on PrEP and sort of have the self-efficacy to say, I'm doing something for my health, I'm going to do more things for my health, similar to what happens when someone starts an exercise program and maybe starts to eat better. So we have a lot of concerns, but overall, the benefits of using PrEP far outweigh those concerns. Abia, you asked the question about cost, and I wanted to include this slide here, which is a slide from Project Inform. It's slightly out of date, this one, because some of the numbers have changed around the poverty level, as well as the support provided by the company who makes the medicine used as PrEP. And this is just a nice schematic to help people, providers and patients, walk through how things are going to be covered. Vanessa alluded to the fact that many of our participants who we surveyed had insurance, and many of our folks who use substances may be on our expanded Medicaid. We are blessed to live in the state of Washington where we did expand Medicaid, and I know some of the people listening to this talk may not be as blessed. But in the expanded Medicaid programs, PrEP, at least here in the state of Washington, is fully covered, including all of the medication, visit, and laboratory costs. So that's why a little bit of the surprise for in our first survey of why knowledge was high and insurance coverage was high, and yet people weren't accessing PrEP. So Medicaid, at least here in Washington, fully covers all of PrEP. Similarly, all of the insurance plans in the state of Washington are supposed to be covering PrEP, although there is a varying amount of the fund deductibles and copays for people, some which are, on the order of $10 a month, which are really quite affordable, to I've heard of plans that people have had to pay thousands of dollars. And for this, the company that makes PrEP provides a copay assistance program that currently provides up to $9,600 per calendar year. It resets every January 1 to help pay for the medication copay costs. Now, they don't also assist for the visit and the laboratory costs, but there are other foundations that you see here on this slide, as well as here in the state of Washington. We have that PrEP drug assistance program that can help pay for copays associated with visits and with lab costs. And then finally, for individuals who cannot access insurance, individuals who are undocumented, the company provides a full medication assistance program depending on people's income that does not require someone to be a citizen in the United States. Now, that unfortunately does not cover the visits or the laboratory costs, but it helps assist in covering costs for individuals who otherwise couldn't access it.
Thank you. That's great. Thank you very much. We have one logistic question about showing the resources screen again. I just want to clarify that all these slides are going to be available in a minute in our website, so you can get to the resource by doing that. I have to go up here. We have one question that is about if you also recommend PrEP for cis men that have sex with women that also inject drugs.
And can you hear me now? I'm sort of not sure whether you've got me speaking now. Okay, great. And so I think it really depends on your epidemic of the local population. And here in Seattle, we generally focus on men who have sex with men and transgender folks who have sex with men. There's also a focus on people who are partners of folks known to be HIV positive, particularly if that HIV positive partner is not currently receiving HIV medicines or not fully suppressed. Because as we know, being HIV positive and on medicines and being suppressed has a near zero chance of transmission. That's the undetectable equals untransmittable, or U equals U that you might have seen around. So, I think it depends, the answer to that question of would we recommend for a heterosexual person. I think it would depend on what the setting is. If they are a sex worker, if they are in a population, particularly if we were in the Southeast with lots of partners, I think it really depends on the epidemiology of the context.
And I think they mentioned if they were an injection drug user too, and it would also depend on, just as we talked about before, kind of what their practices are, and are they sharing needles and who are they sharing with. So if they are sharing needles with many types of men in Seattle who are injecting methamphetamine, the prevalence rates there are extremely high. So like Joanne said, kind of drilling down to the details of what exactly their practices are that are putting them or not putting them at risk for HIV.
Great. Yeah, that's very helpful. There is a question that I think you already covered, but just in case, is talking about increasing resistance, like, similar to antibiotic, if they're also increasing resistance. I believe you covered, but if you want to go about the risk very briefly about PrEP on that, that would be helpful. We have 4 minutes to go, and then we have one more question.
Okay, so so the main concern about drug resistance in PrEP is making sure that someone is truly HIV negative at the time of starting PrEP. Again, in people who were recently infected at the time of starting PrEP, 1 in 3 developed drug resistance. So we both recommend doing a 4th generation antibody antigen laboratory-based HIV test, as well as doing a symptom screen and asking people if they've had any symptoms of recent infection, the fever, rash, sore throat, muscle aches, joint aches, flu-like symptoms. And if anybody has those symptoms, to repeat an HIV test, do an HIV RNA test, do something to exclude the fact that the possibility that those symptoms are acute HIV. There is a large concern that that is sort of an overstated concern that drug resistance will increase in the community because of PrEP. And although there is a slight increase, again, a few people who acquire HIV in the randomized trials got acquired drug resistance, meaning we know that some people will get transmitted drug resistance because there's drug resistance in the community, and then another few percent got drug resistance presumably because they were starting and stopping their PrEP. They weren't 100% protected, and because once they got infected, they took only 2 drugs. That's going to be the next greatest risk of drug resistance, is people who aren't taking their PrEP 100%. Now, that being said, there are at least 2 cases of individuals who acquired HIV infection while appearing to take their medicine every day. The vast majority of people who acquire HIV while on PrEP will do so because of non-adherence. But there have been at least 2, and there are probably more than that, of individuals who look like they were taking their medicine. They said they were taking their medicine, their pharmacy refill looked like they were taking their medicines, and their drug levels, when they did them, looked like they were taking their medicines. And 2 of those individuals acquired a drug-resistant virus, one who had resistance to both medicines and one who had only resistance to one of the medicines. And so PrEP is unlikely to be fully protective in someone, to protect against those viruses circulating in the community that have drug resistance to both components of the virus. It's going to be protective against viruses that have that have only one drug resistance mutation. We don't know how much it protects against viruses that have resistance to both of those medicines, but we also know that at least locally, and I presume it's true for the rest of the United States as well, that the proportion of people who have detectable HIV, who can transmit, who have those 2 drug resistance, is very, 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 very low. So although while it's a concern, and I tell people that PrEP is never 100%, even while they're taking their medicines, the concern about drug resistance is not a reason to not use PrEP.
Perfect. Thank you very much. The last but not least is actually more like a comment and not a question. Somebody commenting that the copay for Truvada could be up to, it's $7,200 a year. If I understand correctly, it's going to depend on the insurance you have, which state we are talking about. But if you have any comment on that.
So I think the question is sort of, so copays vary, the deductible varies, the copay varies. There's some nuances about it, about whether insurance companies are letting people use the copay card, but the coverage as of September went up to $9,600 per year.
Well, that does it. Thank you so much for your time and your wonderful presentation. And for people that are following us, we have in our next month another webinar on harm reduction with Dr. Susan Collins. Thank you very much, and till next month. Bye.